Hello guys, how are you doing? I hope you are revising everything you are reading daily because revision is very important. So I said to you that from yesterday I'm starting to post 5 questions and I'm asking you to answer in the comments below. Yesterday grit@7723 has beautifully commented in a comment section the answers for all the 5 questions. So let's see how many did Grit get correct. So she or he got all of them correct except one. So the score is 4 out of 5. So let's see which question did he or she get wrong. So the first question here is patient with complaints of recurrent kidney stones, abdominal pain and alimentation, decreased calcium, elevated parathyroid hormone. So Grit answered this as B, parathyroid hyperparathyroidism. So why do you think this is the correct answer? What do you think? Here this is not the correct answer because in hyperparathyroidism what happens is there would be elevated PTH and also there would be elevated calcium, but in the option he gave decreased calcium. So it can't be parathyroid hyperparathyroidism. I want every one of you listening to this video to open the calcium topic because calcium has been asked several times in the exam because that concept is very important. I don't want to scare you or tell anything to you, but I want to quickly revise this notes which I have from Prep Ladder, that is Deepak Marva's notes. I will quickly revise it for you because it's very important. So it may take some time, but it's important. So the PTH hormone, it's an important thing. 84 amino acids, who will remember that? Leave it. So what are its functions? What are the functions of parathyroid hormone? It causes bone resorption, because of which there would be increased calcium, and it acts on the PCD part of the kidney, which leads to phosphate wasting. So calcium and phosphate are inversely related. We know this. Calcium and phosphate is inversely related. If calcium increases, phosphate decreases. So as parathyroid hormone is increasing calcium, there would be phosphate wasting. And also it increases bone turnover, that is serum alkaline phosphatase increases. So sir said another point here, that what is the best marker for bone turnover? So the bone destroying action osteoclast, bone forming action osteoblast. Osteoblast forms serum alkaline phosphatase, that's the SAP. In bone resorption what happens is that there would be increased osteoclastic activity, which results in secondary increase in osteoblastic activity, which increases serum alkaline phosphatase. I guess you got this. The point here is what happens in bone resorption. The osteoclast activity is increasing. As the clast activity is increasing, blast think that we need to produce more. So secondary increase in osteoblastic activity, which increases serum alkaline phosphatase. They haven't asked questions such deep, but remembering this basic concepts is important. So what are the must-know points in serum alkaline phosphatase fluctuations? Serum alkaline fluctuations increase in the case of rickets in children and osteomalacia in adults, and hyperparathyroidism primary, secondary and tertiary, because hyperparathyroidism is nothing but increased PTH. So increased PTH means the same thing, increased bone resorption, increased secondary increase in osteoblastic activity and increased SAP. So the same thing here. So if you remember in the first question, in the first day 1 of Neet PG preparation also, we have seen the question in which the SAP has, the serum alkaline phosphate values are increased along with the phosphate values are decreased. That was X-linked hypophosphatemic rickets. So here the same they are telling. SAP increases in rickets in children. And disproportionate increase in SAP is Paget's disease. SAP is normal in hyperparathyroidism, multiple myeloma, osteoporosis. You can remember this, but we can remember that disproportionate increase in SAP is in rickets. That too we revised on the Neet day 1 preparation, that so X-linked hypophosphatemic rickets. If you haven't seen that concept, once check that, it's very important. Now let's discuss primary hyperparathyroidism, secondary hyperparathyroidism and tertiary hyperparathyroidism. So what happens in primary hyperthyroidism is, so the parathyroid is reacting abnormally. it itself is reacting abnormally. So the leading cause over here is parathyroid adenoma. Tumor in any of the parathyroid glands. So the tumor in a parathyroid gland increases the PTH, which increases the bone resorption, which increases calcium. We know that the normal calcium range is 9 to 11 mg%. But here what is happening? There would be the calcium value will increase. So the rise of calcium, what will happen with the rise of calcium? Here 11 to 12 mg% leads to nephrocalcinosis. It can cause renal colic, which presents as flank pain going towards umbilicus, associated with multiple hospitalization due to recurrent vomiting episodes caused by pylorospasm as a result of renogastric reflex. Once they asked enterogastric reflex also in Neet PG question. So here the renogastric reflex, and also constipation due to spasm of the sphincters of the gut, and may present with abdominal pain. So this all these symptoms are all not that important for us, but 11 to 12 mg% is causing nephrocalcinosis, 12 to 13 mg% is causing calcinosis cutis, that is calcium deposition in the skin of the patient, and it's also causing pseudo hypertension, that is hypertension due to hardening of the blood vessels. It's also causing psychosis, that is moaning and groaning. So we know that there is a mnemonic also, bone pain, stones, moans, groans, there is a mnemonic. And 13 to 14, it's also causing secondary Parkinsonism due to calcification of the basal ganglia, that is the symptoms bradykinesia and rigidity, and 13 to 14 mg and higher systolic arrest incident occurs. So these are all the manifestations of increased calcium. So we need to know other important causes of hypercalcemia also. It can be due to malignancy, the squamous cell carcinoma of lung, which releases a peptide, PTH related peptide, and it also causes increased calcium, that is hypercalcemia. Even breast cancer due to osteolytic secondaries also can cause hypercalcemia. Parathyroid adenoma, which might be asymptomatic. Sarcoidosis, sarcoidosis, immediately after reading sarcoidosis we remember non-caseating granulomas, and synthesis of vitamin D3. The treatment of sarcoidosis is giving steroid, and even vitamin D3 intoxication can also cause hypercalcemia. Milk alkali syndrome, that is due to antacids abuse. These are all the other causes of hypercalcemia. So how will we know that the patient is, what we are reading now is about primary hyperparathyroidism. So what we do, we first do the serum calcium. We see that the serum calcium is elevated only here, and as we check the serum phosphate, it will be low, and serum alkaline phosphatase will be high, because as the here, as we have already seen, in case of primary hyperparathyroidism, if the PTH increases, there would be increased osteoclastic activity and increased second increase in osteoblastic activity and increased SAP. So here what happens, increased serum calcium, increased serum phosphate, and serum alkaline phosphatase, decreased serum phosphate, and serum alkaline phosphatase increases. Serum PTH assay also increases. So here tumor localization. So we have seen that there is a tumor here, parathyroid adenoma. This tumor localization is done by the System-EB scan, technetium-99 System-EB scan. This System-EB scan is also used in the case of chronic unstable angina. This is an old edition. If there is any update, please tell me. We'll see this. So this is the workup. So in primary hyperthyroidism, there is increased serum calcium, decreased serum phosphate, and increased serum alkaline phosphatase. So what do we do for the treatment of this? Medical stabilization of hypercalcemia component of the patient, that we give by normal saline, hydration 5 to 6 liters in 24 hours. We give a furosemide drip, which causes calcium loss in urine. We have even discussed in the day 2 of our Neet PG preparation about the diuretics. Revise that also. The furosemide causes calcium loss in urine. And we have even seen a question regarding hydrochlorothiazide, that hydrochlorothiazide doesn't cause calcium loss in urine. So it prevents the renal colic. So in a patient with renal colic, we give hydrochlorothiazide. Revise that thing also. So here, as there is hypercalcemia, we use furosemide, which causes calcium loss in urine. We have even seen in that video that in the case of hypercalcemia, sometimes we use furosemide as a drug of choice also. And we give IV ibandronate, which is the drug of choice. calcitonin nasal spray, which is the antagonist of the PTH, which sends calcium into the bones. There is a high chance of tachyphylaxis for this. And multiple myeloma leading to hypercalcemia, we do the same thing. So, but if in multiple myeloma, uremia features develop, then schedule hemodialysis. The treatment of choice is surgery, that is resection of adenoma. There are indications of this surgery. All these are not needed. What you understood? I guess you understood about primary hyperparathyroidism, that it is because of a PTH adenoma, which is increasing PTH on its own. So PTH is increasing, serum calcium is increasing, serum phosphate is decreasing, and serum alkaline phosphatase is increasing. So I'll make a small flowchart of this. It will be more easier for you. Coming to secondary hyperparathyroidism, what is happening in secondary hyperparathyroidism? The most common cause over here is renal failure. That is chronic renal failure. Because of renal failure, there would be decreased vitamin D3 synthesis. If you remember, in the first video, we have seen the pathway of synthesis of vitamin D, that is SLK. First in the skin, next in the liver, next in the kidney. In the kidney, there is a step. So, if there is a problem with the kidney, there would be vitamin D3 synthesis decreases, which leads to hypocalcemia. So, calcium sensitive receptors are stimulated. So, the body is needing calcium. So, it activates the PTH. It asks PTH, oh PTH, I want calcium, please increase. So, there will be increased PTH. What will PTH do? It will cause bone resorption. So, it will cause to bone pain, rib, vertebrae, or everything will become weak. And what happens here is azotomic osteodystrophy, or this has been also called osteitis cystica fibrosa, or bone metabolic bone disorder, biological derangement in the kidney leading to the pathological fracture, and it causes to cyst in the bones, bleeding, and brown tumor. This is seen in both primary and secondary hyperparathyroidism. But what happens specifically in secondary hyperparathyroidism is the calcium would be decreased. This is because of deficiency of vitamin D3. Phosphate would be increased due to non-excretion of phosphate. You know, calcium and phosphate are inversely related. So, as calcium decreases, phosphate increases. And the SAP would increase because of increased PTH. Because decreased calcium is increasing the PTH. Increased PTH will activate the osteoclast, which in turn secondary activate the osteoblast, and which leads to increased SAP. So, here calcium is increasing, phosphate is increasing, SAP is increasing, vitamin D3 is decreasing. So, if you see here, in the secondary hyperparathyroidism, calcium is decreasing. This is the thing. The treatment over here is we give vitamin D3 and calcium supplements. Kidney transplantation, as the kidney is in chronic renal failure here, and calcium mimetic drug Inicet, which inhibits the PTH release. Coming to the tertiary PTH, which is due to untreated secondary PTH or CKD, continuous stimulation of the parathyroid gland leads to autonomous functioning of the gland. So this is altogether different. I'm hoping that you clearly understood the primary, secondary, tertiary hyperparathyroidism in this concept. Here, what do you think is the answer? Here, if you know the basic concept, by saying decreased calcium, you would first rule out hyperparathyroidism, hyperparathyroidism, though they haven't mentioned whether it's primary, secondary or tertiary. Parathyroid is causing hyperparathyroidism only in primary hyperparathyroidism. So this shouldn't be the answer. And moreover, here there would be increased calcium. Here there is decreased calcium. Decreased calcium is only in the case of secondary hyperparathyroidism, as you have seen. Decreased calcium only in the case of secondary hyperparathyroidism, that too because of chronic renal failure, which is also known as azotomic osteodystrophy. That is a bone mineral disorder, so metabolic bone disorder, the problem with the bone, renal failure, but other options don't at all agree with this. Thyroid hypoparathyroidism, there is no chance of hypoparathyroidism here. Adrenal gland pheochromocytoma also, no chance of here. So here the answer is metabolic bone disorder. Great, at the rate 7723, you answered only this question wrongly. So I have explained this question in detail. Hope you understood this. Coming to the second question, so here we are asking about the ulcerative colitis and Crohn's disease. Great, answered it correctly. So we are here finding the answer, features of Crohn's. Continuous lesions rather than segmented lesions. No, in Crohn's there would be skip lesions. So this is wrong. This doesn't relate with Crohn's. Associated with increased risk of developing cancer. No, both Crohn's and ulcerative colitis have a same chance of developing cancer. This has been given in the notes also. In your notes, open your notes, you will find this point compulsorily. Less risk of perianal fistulas. No, in Crohn's there would be more risk of perianal fistulas. So ruling out these three options, it would be the answer. So less likely to present with daily hematochezia. No, there would be more chance of presenting with the daily hematochezia. And you need to remember this table, the difference between Crohn's disease and ulcerative colitis. Please remember this. This is very important. Take a screenshot of this because any question they can ask from this, both any combination they can ask. Here they ask skip lesions, they ask with the malignant potential, both are same, perianal fistula. Yes, in the case of Crohn's disease. So this is important. Coming to the third question, which of the following is the for some dehydration? So this chart which I am putting here, this chart is very important. Open your books, revise now. I want everyone seeing this video to answer this question because this is very important. I don't want to explain this to you because this is just the yes or no type of question. If you know this, if you don't know, the same thing. So you need to answer this question. You need to mark this question. You only tell me this answer. Coming to the fourth question, so they're asking what is this? Great, answered this correctly. This is yes, chronic malnutrition. Why? Weight for height is less. So any malnutrition, cutoff for malnutrition is less than -2 standard deviation. So here the cutoff is weight by height is less than -1.7. So this doesn't come into the picture. So height by age is less than -2.5. This comes under chronic malnutrition. Weight by age less than -3.2 standard deviation. Weight by age is not that anything that is very important. We only consider height by age and weight by height. So weight by age -3.2 standard deviation is only underweight, as explained by the Marrow faculty, sir, Pediatric sir. So here the answer is chronic malnutrition only. If you have any doubt in this, open your book, revise this again. This is very important. And coming to the third question, which of the following condition may lead to a decrease in GFR? This I have already explained to you in a earlier video. This question is been asked again. I have posted this question again because I want to know you the importance of knowing this question. If you are preparing for Inicet, don't go to the exam without studying this topic, GFR. So here the answer is increase in Bowman's cation hydrostatic pressure. As you know, we have seen earlier in a video also that the factors favoring filtration are the hydrostatic pressure in the glomerular capillary, and the factors opposing filtration are the oncotic pressure in the glomerular capillary and the hydrostatic pressure in the Bowman space. So oncotic pressure in the glomerular capillary and the hydrostatic pressure in the Bowman space. So here what he gave, increase in Bowman's capsule hydrostatic pressure. So in hydrostatic pressure in Bowman space is an opposing force. If you increase the opposing force, of course there will be a decrease in GFR. Coming to the other option, increase in glomerular capillary hydrostatic pressure. Glomerular capillary hydrostatic pressure is a factor favoring filtration. So if you increase that, of course there will be increased GFR. So here there will be increased GFR. And decrease in glomerular oncotic pressure. If you decrease in glomerular oncotic pressure, that is a factor opposing filtration, there would be increase in GFR, because you are decreasing which is opposing filtration. So here there would be increased GFR. Even if you increase the renal blood flow, there would be increased GFR. So even by ruling of the options, this is absolutely correct. So great@7723, you have answered all the questions beautifully, but you have missed only this question. Please look into this topic. That's it. So in this video I have explained the 5 questions which I posted yesterday, and I want everyone to answer this question. This is very important. So how do you like this series? So one day I will post the questions, next day I will post the explanations. In that way we can't the video might not be that long, and you get the feeling that even though you are not revising yesterday, you can revise this today and get ready for the questions which I post tomorrow. So what do you think about this? If you like the channel, please like the video, because it takes a lot of energy of me doing a first year of PG residency to post these videos. And if you like the content, subscribe to the channel and share this to your friend. Don't forget to read the calcium topic today, that's primary, secondary, tertiary hyperparathyroidism, and don't forget to post this answer today. See you tomorrow.